The Society for Vascular Surgery, under the leadership of Richard Cambria and Peter Glavitsky, has initiated an audiovisual interview series with the pioneers of vascular surgery. This is part of an effort by SVS to develop archives to preserve the history of SVS as well as vascular surgery as a specialty. A committee was formed called the History Project Work Group, chaired by Jimmy Yao, with Norman Rich and me as members. Cal Ernst has served as our consultant. Because of the workload, an expansion of this committee was needed. Bill Baker, Mark Eskandari, Walter McCarthy, William Pierce, Melina Kibbe, and Peter Lawrence were added. My name is Roger Gregory, and today we will be interviewing the renowned surgeon and leader, Larry Hollier. Larry, thank you for agreeing to this interview.
Happy to be here.
Let's start from your early years. You were born in Crowley, Louisiana. When were you born?
1943.
Tell us about your parents.
My parents were from small towns near Crowley. My mother was a housekeeper. My father had been raised on a farm, left home around the age of 16 and went to work riding logs on the Mississippi River out of New Orleans. Ultimately moved to Crowley and developed a business in the hardware store, developed a hardware business, and also was a farm implement dealer and was the manager of the John Deere Tractor Company in Crowley, Rice City Tractor Company. And as a young guy growing up, I knew that I had summer jobs, which was basically working as a mechanic in the combines in the rice fields. I was the only one small enough to get on top of the straw walkers that go back inside the combine. When it's 105 degrees outside, it's a bit more than that inside that oven of the combine. And I thought there might be another type of job that I'd prefer to do in my life.
Was your dad an influence, do you think, Larry?
Very much so. Very quiet man, very generous. Actually developed the patent for the hydraulic lift. And because he was working for the other company, he assigned all rights to that to John Deere. And, but a very honest individual, very forthright, and very diplomatic, understood how to work with people, and was very successful.
You have any siblings?
I have a sister who's 13 years older than I. My wife says that I've had two mothers because my mother and my sister both took care of me, and she says, of course, they always said you could do no wrong, but I'll tell you differently.
You went to grammar school in?
Grammar school in Crowley, went to high school at Immaculata Seminary in Lafayette, studying to be a priest.
Really?
Right, was there for 4 years.
Did you have any thoughts about an occupation there beyond the priesthood?
When I was young, my mother was very religious. We went to church every morning, and I became an altar boy at about 5 and a half. Became the altar boy for the bishop who had just moved to Crowley, auxiliary bishop. And I was just so much involved with that it just seemed natural that I would go on to be a priest. After I got to the seminary, I realized that's not kind of the lifestyle I wanted either. It was somewhat not even as attractive as working on the combines. So I decided to leave there. So I finished high school there, didn't want to quit in the middle of something. So I finished high school there and went to LSU and just knew that I was going to be a physician. Don't know what led me necessarily to choose medicine.
Right.
But it seemed like something I wanted to do. And I've had a great time.
You went to medical school at LSU, 64 to 68.
Right.
Also in 64, you got married.
I did. Got married after I got accepted to medical school. Diana, my wife, is from Crowley also. We met one summer while I was working in Crowley, and dated in college, and got married right after I got accepted to medical school. So we moved to New Orleans and started raising a family.
Now, your two children, Larry Jr. and Michelle, are they, tell us about them.
Our daughter Michelle has 3 boys.
Mm.
She's a speech pathologist, works in Dallas, Texas. And our son and his wife and one son live in Houston. Our son is a craniofacial surgeon, just got appointed as the chief of plastic surgery at Children's Hospital in Baylor. His wife is a high-risk OB, and she was at UT Houston and is now at Baylor. Very successful kids.
Wow. I've heard nothing but good things about your son in practice.
They're doing well.
Now, why did you choose surgery?
I didn't know exactly what I wanted to do. In medical school and everything I saw, I wanted to do everything. I just didn't want to be limited. So again, this is back in the '68. That's the early days, and general practitioners in my area could do everything. They delivered babies, they operated, they took everything. And I liked that idea. So I was really thinking of going into family practice, or general practice as we called it then. And I did a rotating internship. During my internship year, I wanted to learn more about what it was like to live as a general practitioner. So I went to work on my vacation with a general practitioner in Gaydon, Louisiana. He was the only physician in town. There was a little 30-bed hospital that was sort of his hospital for the town. And when I went to talk to him, I said, I just want to follow you around for a week. He said, well, I don't know about that. I said, I just want to sort of get an idea of what it's like. He said, well, how are you able to do this? I said, well, I'm on vacation. He says, you got a vacation? I said, yeah. He says, how long? I said, well, 2 weeks. He said, oh, man. He said, I hadn't had a vacation in 3 years. He said, look, I tell you what, how about if you just take over my practice while I'm gone? I said, no. I'm just an intern. I'm not sure I really want to do this. No. He says, I'll pay you $75 if you'll cover for the weekend for me. I was making about $100 a month for a weekend. I thought that was big time. So I agreed to do that. So I figured 5 o'clock Friday evening, I arrived at the hospital. And the nurse there says, oh, glad to see you. He said, we have 30 patients waiting for you. I said, I just want to talk to the doctor. He said, oh no, he left at noon. So I wound up covering this hospital all weekend. I saw more things there that I think I had seen at Charity Hospital in New Orleans. I had a crop duster that crashed. I had a kid that broke an ankle in a high school football game. A 32-year-old lawyer that held the church's money had a heart attack in his home, and I said, you got to make a house call. I said, no, I don't make a house. Oh no, you got to go make a house call. So I spent the weekend there. The only thing that bothered me was when I got word that they were bringing in the pilot who had crashed his crop duster. And I thought to myself, you know, if he's got a ruptured spleen or something, I'm going to wind up having to operate him. There was no good way to move people around. And I said, I don't feel comfortable doing this. I think I need to be a surgeon. So that was a decisive moment. And
It was a branch point right there.
Right, and I said, I need to be able to make sure I'm capable of doing everything that I want to do. And went into surgery.
Now, you did your residency at Charity.
Right.
And in the middle of your residency, it was interrupted by going in the service.
I graduated from medical school in 1968. That's the year of the Tet Offensive. Mm-hmm. Virtually everyone from my class, all the males in the class, you were drafted in those days.
Right.
You had the option of going on the Berry plan, which you might be able to finish your residency, or if not, you would at least get 1 year before you had to start. So I volunteered for the Berry Plan, was in the Air Force, and I got a 1-year deferment. So I'd done an internship. I did 1 year of residency, and then went into the Air Force, stationed in Montgomery, Alabama.
Was this valuable time?
Turned out to be very valuable time from two standpoints. In Montgomery, Alabama, it's that hospital, Maxwell Air Force Base, was the Air University, Air War College. So we had a large number of brass in that base, and the hospital was well staffed. But I went in as a general medical officer, and I was assigned basically a clinic where I would see patients every half hour or so, and I was really bored. And I really wanted to do surgery anyway. So they had 3 surgeons there. They were all board certified. One of them had done a year of his thoracic residency, so they were well-trained individuals. And so I really wanted to be operating, but I had my GMO work I had to do. They had what they called a lumps and bumps clinic twice a week, 2 afternoons a week. So I asked him if I said, you don't really need to take out lumps and bumps. How about letting me do that for you? And he said, well, you can't get out of your clinic. I said, no. I said, I got so much time. I'll do it plus my regular patient load. He said, that was fine. So I started doing the lumps and bumps. Got to cut again. The other thing was I needed to be in the operating room. And I found that there was a regulation in the hospital that if you were doing a laparotomy, you had to have a second surgeon in the room. So they would have their regular call rotation, so I talked them into letting me just take call every night as that second surgeon. So if they had something, then I could be in there and operate. So I started doing that. Then I had a half day off, and I said, look, instead of my half day off, why don't you let me just operate with you for that half day? So after a couple of months, they said, this is crazy. Why don't we just move you to surgery? I said, yes. So I was moved into surgery and did that for the rest of my time. Worked with an individual, Matt Burns, a surgeon who had been a career Air Force surgeon. And in his training at Emory, he had spent an extra year with Garland Purdue doing vascular surgery. The thing that I found so impressive was that the results were always outstanding. I mean, we never had any significant vascular complication when I was there. And again, the turning point for me in vascular surgery, whenever I would see in the office, if I thought they needed surgery, then for them that was my patient, and they would just help me do the case. So I found a woman who had aortoiliac occlusive disease and bilateral SFA occlusions, severe claudicat, and I thought she needed an aorta bifilm. So they reviewed the films with me and they said, fine, when do you want to do it? Well, we'll do this tomorrow. They said, that's fine, we'll help you. Started off in the morning, and again, I remember I had 1 year of general surgery residency, so this was a great case for me. So I started off, and they never did anything except assist me. So I did the aorta film, finished, checked the pulses, and of course you couldn't feel pulses then. The legs were a little cool. But again, they didn't make any statement. Just, what do you want to do? I said, I really think we need to do a left film pop on this patient. I'll help you. What do you want to use? I said, well, I think we ought to use saphenous vein. Said, okay. Took out the saphenous vein, did the film pop, and really did not have good pulses. It was an inadequate vein. Today I know that, then I didn't. He never said that. So he says, what do you want to do? I said, really, I hate to do this, but I think we got to change it. I think we ought to use a prosthetic graft. He said, I'll help you. So we did that, finished up bounding pulses. He says, call your wife and y'all come over, we're going to have dinner at my house tonight. I went over there. But before dessert, I went back to check the patient, make sure everything was going well. From that point on, there was no question I was going to do vascular surgery.
So then...
Good mentors make a difference.
Absolutely.
And that was a turning point again.
How did you hear about the Vascular Fellowship in Dallas?
Well, when I finished my tour in at Maxwell Air Force Base, I had been doing surgery for most of the time of those 2 years. But again, I had to go back into my general surgery residency. When I went back, I negotiated with Dr. Isidore Cohn, who was the chairman there, that he would give me a year's credit from my time in the service. I had my case list, I had everything else done. He just didn't want to do things like that. I said, well, you'd still miss time. You know, you're not getting out until September. I said, no, I want to come back in 3 months into my 3rd year. He says, well, why? He says, it's just not enough time. I said, look, I won't take any vacations for the rest of the residency if I can just do that. I'll make up the time. He said, okay. And then I was back it was a 4-year residency program at the time, so I was in my 3rd year. We had a visiting professor that would always come down for the Reeves Society meeting every year in New Orleans. And one of our former graduates, surgeon that I had worked with when I was an intern, first year resident, had actually gone to Jesse Thompson and done a fellowship there and had become Jesse's partner. And as we were talking, I told him what I wanted to do. He apparently talked to Isidore Cohn and indicated that. So he had given me such a buildup of Jesse, I was really very interested in doing that and had decided that's what I would do after I finished my residency. So time went on, and one day I'm operating and I got this call into the operating room from Dr. Cohn's office. Nurses, Dr. Cohn would like to see you at your earliest convenience. Oh, Lord, what did I do now? Figured I was in trouble. Had trouble finishing the case. Went over to his office and he says, sit down, Larry. I said, oh, this is going to be bad. And he comes around and says, how's things going? I said, they're going to find out. I'd really like to finish my residency. He says, no. He says, I understand you're interested in vascular surgery. I said, yes, I'd like to do that after I finish my residency. And he says, his process was that every year he would send one resident away for an extra year. And after that, that resident would come back as the chief resident of the program. What he was offering me was a year away to come back as the chief. And so I said, yeah, the only place I really want to go is with Jesse Thompson. He says, if I can arrange that, would you do that? I said, absolutely. So I wound up as a resident with Jesse, and it was a fantastic year. Again, another career-changing move.
Yes.
Because it was very different in technique and style compared to what we had learned at Charity Hospital in New Orleans. Everything was regimented. It was a standard way of doing things. As Jesse would say, I always do it this way. There's no ways to change it. It always works. We do it this way. And it was very standardized. It was in the days of some changes in fluid management in vascular surgery. In that area, Jesse was at Baylor University Medical Center in Dallas. Tom Shires had been obviously at UT, and so we had a different management from what we had been taught, which was the old Franny Moore way of fluid restriction postoperatively. And patients did great. And so when I finished that year, I had to still do my chief year.
Right.
And I went back, but Jesse had offered me a partnership with him, wanted me to come back as his partner, which is the only thing I really wanted to do. That was just great because he was busy operating all the time, and I thought this would be great location, great hospital. So I agreed to do that. And then toward the latter part of my senior year, Isidore said, Larry, you got to stay here on the faculty. I said, no, I'm going to be Jesse's partner. And really wanted to go. He said, Larry, he says, look at the mortality rate at Charity Hospital in vascular disease. And a paper had just been published that had looked up mortality, looked up aneurysm surgery. And at Charity Hospital in that time, the mortality rate for elective aneurysm repair was 24%. primary causes of death was exsanguination on the table. Secondary cause was infection. Third was renal failure. Myocardial infarction was a distant fourth. And he prevailed upon me to stay. And so I did. I started the vascular surgery division there with Bob Batson, who followed me with Jesse the year after. And then when I went on the staff, Bob came back as chief resident. We worked together there and then joined me in practice.
That was when Batman and Robin
That's correct.
came to pass.
That's correct.
Now, you stayed at LSU, Larry, from 75 to 79, then and rose to assistant professor, then went to Mayo Clinic. How did that happen?
Sort of serendipitously, I guess. I was perfectly content operating at LSU, and we were busy. We developed a very busy practice, and Bob and I were operating in primarily at Charity Hospital, at Hotel Dieu, a private hospital, in the VA, and there were 3 other private hospitals that we'd occasionally do cases in. And it was busy. We got to know different physicians and surgeons in town. There was one of the local societies. And I used to play racquetball with a guy who was head of pediatric surgery at Tulane. And one day he called me up and said, listen, I have a friend of mine who had trained with me at Mayo, and he'd like to do a little mini vascular fellowship. What are you talking about? He said, well, he'd like to come down and work with you for a couple of weeks just to get a little training in vascular surgery. I said, 2 weeks is not very much to do. I know, but he'd just like to do this. I said, fine. And so guy comes and visits with me, and it was an intense 2 weeks. He would meet me for breakfast in the morning. He'd be there for dinner at night, and it went on constantly. So at the end of that, he said, my wife would like to come down and spend a little time. So Diana, my wife, said, she'll entertain her. So after this 2 week period, the only thing I noticed that was a little unusual was one day Bob was doing a renal bypass at the VA, and I had an access case at Hotel Dieu. And I told the guy, I said, look, you're going to want to go and watch the renal bypass. He said, no, I want to watch you. I said, I'm just doing an access case. Yeah, I just want to go watch you. Thought it was kind of strange. So at the end of the 2 weeks, he said, listen, I'm really here because Mayo is looking to hire somebody to start a vascular surgery program. And he said, I was really just scouting you out. And he said, I really think you need to take this job. I said, Mayo Clinic? I said, isn't that up north? And he said, well, yeah. I said, listen, I worked in the north for 2 years when I was in the Air Force. I'm never going that far north again. And he said, well, where were you? I said, Montgomery, Alabama. I said, I just don't want to go that far north. And he said, well, just come visit. So at the vascular meeting that year was in Nashville, I met with some of the guys from Mayo. And Mayo had, at that time, 7 vascular internists.
Right.
Alan Barker and Hines had written the textbook in vascular disease management. They were at Mayo. And they had this tradition of training guys who just saw vascular medicine problems. And I met with them, very interesting because they obviously had case volume. And I said, why do you need somebody else? He says, well, we don't have anybody here who really is dedicated to vascular. And I said, but why would you need somebody else? He said, well, let me give you an example. It's just John Joyce talking vascular internist. And he said, yesterday, on my lunch hour, I saw 3 extra patients. Well, I thought that was interesting in itself to have an internist who would actually see 3 extra patients. I just liked that work ethic. And so he said, there happened to be 3 aneurysms. And he said, I had one of them that was 8 centimeters, another one that was 6 centimeters. And he said, the earliest I could get the 8 centimeter done is 2 weeks. And the other one, I can't get it done for 6 weeks. And I said, I'd have done all 3 tomorrow. He said, well, that's why we'd like for you to come. I said, I'll go take a look. So I went up there and as I went around and saw the case volume, it was just a heaven for a vascular surgeon. There were cases, good cases everywhere. And I my wife was eagerly waiting to hear what my response to this would be. So we just moved into a house we'd renovated about 3 months before, and I called her up and told her. She said, "Well, how is it? How is it?" I said, "Well, you know, it's okay. It's very interesting. I'm trying to be non-committal." And I found out later when she hung up the phone, she turned to the kitchen and says, "Damn it, I think we're moving to Rochester." And so we did. We were there for 7 winters.
That's how you counted it.
That's how my wife counted it.
I know how you mean. But that was a great time for you, wasn't it, Larry?
Wonderful time.
Yep.
Wonderful time.
Now then, somehow we keep getting back to Louisiana. This time it's Ochsner Clinic. Tell us about how that happened.
I'm happy to do that. Let me tell you something about Mayo first, if that's okay.
Oh, sure.
Again, this was in the relatively earlier days of vascular surgery. And to me, at that time, there were only a few areas in the country that I thought were really recognized in doing complex vascular cases. There was the Houston group, Jack Wiley in San Francisco,
Right.
Jesse Thompson in Dallas, the Harvard group, Clem Darling and others there. There were some others, Cranley, and then in Nashville,
Bill
Andy
Edwards.
Dale was there. They were not doing the same level of complex cases. So I sort of looked at this and I said, as I read different things, I saw that Houston, San Francisco, Dallas, and Boston were doing things differently, but were prominent in there. So one of the reasons that Mayo had recruited me was they wanted to develop a vascular surgery division and training program, which is what I was interested in doing, because I started the vascular program with Bob Batson in New Orleans, training program. So my plan was to hire my next faculty from those different centers to get us all together. So when we would work together, we would learn the different techniques and then come out with something that was really the best of all worlds. So Pete Parolero at Mayo had trained in Houston. I had trained with Jesse. So my first hire was somebody from Jack Wiley's program, Ken Cherry.
Right.
And then our next hire was Jeb Hallett from Boston. So we put together that group, and it was a very interesting experience because as we worked together, we sort of worked out techniques that really worked the best, and that was a very rewarding experience.
Tremendous.
Yeah.
Tremendous. Now let's get back to Ochsner Clinic.
Ochsner, I got a call that Ochsner was looking for someone to be the head of surgery, chairman of surgery there. John Ochsner was retiring. He wasn't retiring. He was stepping down as
Right.
chairman because of their mandated 65 age rule. And I went down to look at that, and it was a great opportunity. It had a lot of case volume and everything, so I thought it would be a challenge to take on a general surgery department, and went over there. So that was great. John Ochsner was great to work with. And we each had 2 operating rooms. They were in a row in the back part of the operating room area, and we had a large office across the hall. So John and I shared that office between cases. We'd operate on the same days. We'd operate Monday, Wednesday, and Friday, and would have discussions back and forth. And so it was a great interaction that we had.
Now, Larry, after being at Ochsner Clinic until 1993, suddenly the idea of Scotland comes up. You were recruited by Harvard to direct this adventure in the Department of Surgery in Glasgow. How did that happen, Larry? And what were your goals and expectations? And
Had no thought about leaving Ochsner. We were settled in New Orleans. Everything was going great. Our daughter moved back to New Orleans, where she went to LSU to complete her master's in speech pathology, and our son moved back to New Orleans to start medical school at Tulane. So they had been there, they had finished their training, and they had gotten married and moved on. But we were very content in New Orleans. I had a meeting in London. Diane and I went, I think it was Roger Greenhall's meeting.
Right.
And John Maddock and Jesse Thompson were great friends. And they invited Diane and I to go out to dinner with them one night. John Maddock at Harvard had sort of been shepherding this project of Harvard wanting to build a U.S. academic medical center in Europe. The concept, they told me, was that a couple of their pediatric surgeons had noted that over the last several years, a lot of the patients that they were getting from Southern Europe and the Mideast were dwindling. They were now moving more and more to London or to Italy, to Germany, because healthcare in the United States had escalated with cost shifting that went on. So their concept was they're coming for U.S. academic medical center. United Arab Emirates, for example, would send 100,000 patients a year for healthcare out of the country. They paid the freight. So Harvard felt that if they built this U.S. academic medical center in Europe, they could do it in a cost-effective way. We could bring U.S. docs. So we're having dinner, and John is telling me about this project, John Manning. And Diane and I had planned to just take a week's vacation while we were in Europe. We were going to rent a car and travel around. I said, listen, we're leaving Wednesday to go to Scotland. Take a look. Why don't you come with us? Just take a look at this project. Diane and I talked about, well, we could start our tour in Scotland, rent a car there, and we'll drive down, go through the Lake District, and all that'd be fun. So we went over there, and they were building this 500-bed state-of-the-art hospital, 157-room, 5-star hotel. And it was a very exciting project. And so they said, why don't you think about coming over here? I said, for what? They said, well, we need somebody to build the medical staff. He said, at that time at Oxford Clinic, I was head of surgery, but I was also had been elected to the board of management. Oxford was a self-run, physician-led organization. I was on the board of management. He said, you're running a multi-specialty clinic now, but how about building one from scratch? You can build it the way you think it ought to be done. I thought that was sort of an intriguing possibility. But they had another guy that they had already pretty much identified that they were going to select to lead this, Mike Weidenheimer, great guy who had been at Leahy Clinic.
Right.
And so we go down there and we're looking, and they're talking to us, and I'm meeting with the CEO, a very charismatic individual named Jim Wigsine, who had been a Harvard administrator at the Brigham. And he's explaining their concept about this, and he says, we're building this project, and it's an exciting project. And he says, we decided what we would try and do is identify academic surgeons and intern, specialists, sort of at the peak of their career, where they're getting ready for retirement. And so we could bring them over here, and if it doesn't work out, they're ready to retire anyway. I said, gee, I guess I wouldn't do it that way. He said, what do you mean? I said, well, if I've got a complex project, I'd want to get somebody at the peak of their career, because then they can't let it fail. He said, oh. And I just went about looking around, met other folks and so forth, and around 1 o'clock, everybody got together, and Mike Weidenheimer had been there interviewing, looking at the job. And Mike walked up and he says, you Larry Hollier? I said, yes. He said, I'm Mike Weidenheimer. I said, yeah, I heard you were here. He said, well, I came over here thinking I was going to run this project, and now they tell me they're going to give it to you. I said, no, wait a minute. I'm not coming here. My wife never said anything about this. We ultimately looked at the project, and I was very nervous about leaving the United States and going to do that. And, sometimes you just want validation of what you're going to do. And so I called up Norman Hertzer. Norman Hertzer and I were good friends. We had been competitors on a yearly basis at Cleveland Clinic. You know, everybody's got to have their coronary angio studied and fixed before you operate. Mayo Clinic, which you don't really need to do that, you can get them through. So we had debated back and forth and became friends. So I called Norman. I said, Norman, I want to run something by you. And I told him about the project. And I said, so they've asked me to come over and start this medical group over there. I said, tell me what you do. And there was a silence, and he says, geez, Larry, I could never do that. And I remember I was disappointed because I wanted him to say, yeah, go for it. And I said, oh. He said, no, he says, you have to do it. I said, wait a minute, what are you talking about? You wouldn't do it, but why do I have to do it? He said, Larry, we're just different. And he said, if you don't go and it's successful, you will always say, I could have done that. But if you don't go and it's not successful, you will always say, I could have made it work. He says, you got to do this. And so we did. And it was a great experience. I learned so much from that.
We're going to come back to that
Okay.
and shortly. But after Scotland in 1996, you returned to the United States, this time going to the deep north, Mount Sinai,
north of Minnesota.
in New York, where you became the professor of surgery in the Chairman Department. I might add that when you took this job, they were $100 million in deficit. Larry, why did you take this job, and how did you dig out of that?
First of all, they weren't in deficit when I took the job. They were thriving. Jack Rowe was the president and CEO of Mount Sinai, and they were doing very well, but they had decided that they were going to merge with NYU. And I remember Jack Rowe called me up after I had accepted the job, and said, listen, I just want to let you know that you're coming down here. I don't want you to be aware there's going to be an article in the Wall Street Journal tomorrow talking about Mount Sinai and NYU merging. And he says, we're going to do everything in a deliberate fashion. We're not going to go and radically change things. As one chairman retires, then the other would just subsume the other thing. We take it together like that. And he says, I don't need to tell you that your counterpart in surgery at NYU is Frank Spencer, who's
Right.
I think was 80 years old or
Right.
late 70. So he says, you would assume that. I said, fine. So I came over there, and that really never did integrate. What happened is that we had a great time. It was very busy over there, and we were doing a lot of surgery, but the administration took their eyes off the ball because they were trying to work the backroom functions, integrating two disparate cultures. And over a period of several years, things did start to get into financial difficulty, and they wound up at a point where they were going to be losing about $35 million. They hired the Hunter Group to come in and sort of tell you how many people you need to fire and move out to get things reorganized. The Hunter Group left, and 6 months later, nothing had changed. And so one day, in October, the board at Mount Sinai removed the president, vice president, chief operating officer, chief financial officer, several vice presidents. And I wound up being appointed president and chief operating officer of the hospital.
Right.
And actually they gave me a chief financial officer from the pantyhose industry. It did not make it easy. But as I went through everything, it became evident that they were losing a lot more than that. And I went back to the board a few weeks later and said, you're not going to lose $35 million. You're going to lose $150 million this year. And needless to say, the board chairman got a little weak and white. And so we just started a massive turnaround, and I learned a lot about that too. We did a turnaround that took out $70 million that first year and put it on the slope to recover. It's been very successful now. And then shortly after I became president, LSU had come back to me and said, look, we're looking for a dean. We'd like for you to consider this. And I said, I can't. I've got to fix this thing.
Was Mount Sinai your first formal administrative role, Larry, in your eyes?
No. I mean, my first administrative role, I guess that required diplomacy, was at Mayo, setting up a separate division of vascular surgery. When I arrived at Mayo, Bob Wallace had been the chairman of surgery when I was when I was recruited. And when I arrived at Mayo several months later, April 1st, 1980, I'm walking into the door and Bob Wallace is walking out, got a suitcase in his hand. And I said, Bob, he says, Larry, I meant to call you. I said, what are you talking about? He said, well, he says, I'm leaving. I'm taking the chair of surgery at Georgetown. He said, but go up to my old office. The new chairman is there, Don McElrath, and just go introduce yourself and talk to him. I said, okay. So I went up, knocked on the door. Dr. McElrath says, yeah, who are you? I said, I'm Larry Hollier. He says, who? I said, I was hired here as a vascular surgeon. He says, why? I said, well, I was recruited to come here and set up a new division of vascular surgery. And again, remember, this is 1980. There was this sort of schism between general surgery and vascular surgery. And he says, well, I can tell you, I'm not going to have a division of vascular surgery in my department. I said, well, Dr. McElrath, we have a problem. I said, I accepted the job here. I've sold my house in New Orleans. I bought a house here in Rochester. I moved my family here. He said, well, you can stay, but we're not going to have a division of vascular surgery here. I said, this might be a little tougher than I thought it was going to be. But we persisted and kept at it. And they didn't know exactly what to do with me because I said, the agreement was I was going to do pure vascular surgery. I didn't think you could be torn in multiple directions. If you're going to build it, you have to focus. So I wanted to be focused in vascular surgery. So the only place that they thought they could put me was in cardiac surgery. Cardiac surgeons didn't particularly like it because I couldn't cross-cover call for them. And Mayo at that time was splintered as far as vascular surgery. Ruptured aneurysms were done by the trauma team. Carotids were done by neurosurgery. The pulmonary surgeons, Phil Burnatch and Spence Payne, did the viscerals and the renals. Orthopods did fem pops because they'd come in with leg pain. The elective aneurysms were generally done at the end of the cardiac list of the day, and it was done by the cardiac residents. And then there was a separate division of vein surgery. And so this was what we were starting with. So I started by just putting together a group of the internists, and we started a weekly conference, case presentations and discussions of results and so forth. And we built it from that, hired Ken Cherry, who came in and joined me. And again, in retrospect, you can understand how things happen. It's often serendipitously. And as I said, I remember I was doing a thoracoabdominal one day because the internists would refer the cases to whoever they were, the vascular intern. And Jim Pluth, head of cardiac surgery, came in and looked over my shoulder. He said, what you doing? I said, I just got a thoracoabdominal. Oh. I didn't realize that at that time that was a cardiac case. If it was referred to me, I did it. So I was just sewing in the proximal anastomosis. He says, I got to go do a mitral. Came back about 20 minutes later, and I'm sewing in the visceral cuff. He said, same case? Yeah, same case, yeah. So going, I got to go do another mitral. Came back at the end, and I'm closing up. He said, how'd it go? I said, went fine. I didn't think anything about it. It was just another case. Yeah, I noticed that several other times he'd come in and watch when I was doing thoracoabdominals. And one night at a staff meeting of the section of cardiac surgery, Ken Cherry and I were there, and at the end of the discussion, I was always kind of bored because they were talking about cardiac issues, and one of the young guys, when they said any new business, and one of the young guys says, well, he said, I think we have to have a regulation within the division. About what he said, well, he says, I think if you're going to operate in the chest, you need to have your thoracic boards. And I sort of perked up about that because that seemed like a threat to me. And I said, well, Jim says, just be quiet, Larry. Tom, tell us what you're talking about. He says, well, for example, thoracoabdominals. I think you need to have chest boards if you're going to do that. And I began starting to get riled up and said, Larry, just be quiet. He says, Tom, what are your results with this? He says, well, I don't know exactly what they are, but I know that when you have the experience. I said, well, I can tell you what they are because I've looked them up. He says, okay, what are their results? I said, got a 20% mortality rate. He said, and what are your results, Larry? And I said, well, I've only done 24, in the last year, but I said, I've had no deaths, no renal failure, no paraplegia. And he turned to the cardiac surgeon, and he says, Tom, he says, why should we tell Larry and Ken that they can't do thoracoabdominals? Is it because their results embarrass us? He said, I don't think we need to talk about this anymore. And the next day, went to him, the chairman, I says, I'm either going to have a separate division of vascular surgery or we're out. And so Ken and I felt that was the deciding moment, and they agreed. So we developed a separate division of vascular surgery there.
Another branch point.
Another branch point.
Now, Larry, when you were in New York, clearly you put the focus on the fact that now a surgeon was directing the healthcare system, despite the fact that doctors had always been portrayed as poor businessmen. Yet you succeeded. Why?
And I don't think that any one individual necessarily knows how to manage all the nuances of a hospital. I had a very good administrator who worked with me in Scotland, Victor Yick. And Victor was very methodical, and we built relationships. And there were a group of vice presidents at Mount Sinai in the different areas of the hospital. Supply chain management had an individual, human resources another, nursing was another. And when we got into this financial issue, and I wound up being appointed president, Victor and I worked very closely with the vice presidents that had each of these divisions, and we empowered each of them to do what they needed to do to improve things. And I think empowering people who are responsible for their areas, they know that better than I could ever know it. And so they took this on, and what we said, I trust that you will do it. The only thing you need to tell me is if you're having a problem that I can help you with, and I will come in and get in. But otherwise, here's where we want to go. Here's the vision of what we're going to do. You do it. And just let me know when you have any obstacles, and I'll take care of it. So empowering them to go out and do this made a big difference. I mean, for example, we took out $17 million in supply chain just by getting the doctors to work together and decide, we have a financial problem here. Let's focus. We're going to cut down. Instead of having 6 different hip prostheses, we're going to have 2. Okay. And it went like that across the area. And I think having people empowered to do the job that they know how to do is the way you move things. It was a very fascinating experience to me because having to deal with the different issues. For example, the unions were a big issue in New York.
Right.
And when you have a $150 million deficit, you're going to have layoffs. And the unions were powerful. Dennis Rivera, who was the head of the 1199, basically could elect the governor by mobilizing his forces. So one of the first things I did was I called the union representatives at the hospital in to meet with me. And I told them that, I said, we have a massive financial issue here. We're going to have to fix this. And I said, I can't believe that we're going to do this without layoffs. The loss is just too much. I said, but I don't know how to do that. And I said, you guys are the leaders of the union. You're going to have to do this. And so I need to trust you to make this happen. And so, again, a very interesting learning point there. After I finished my little brief spiel, they were sort of quiet. I said, let me try and answer any questions you have. And I said, and Doctor, first of all, let me tell you that we appreciate the respect that you're showing us by meeting with us. He said, nobody had met with us for 20 years. Not really true, but that was the comment that he made. He said, but you know, we understand, but he says, you're going to have to talk to Mr. Rivera about this. I understand, I'll go meet with him. So we arranged a meeting, and he was going to be coming over to Mount Sinai to meet with me one afternoon at 5 o'clock. That day, it was pouring down, one of the biggest downpours I've ever seen in New York City. And my secretary called me and says, Mr. Rivera says he's going to have to cancel the meeting because he's got to go out of town. I said, call him back and see if I go and see him right now. It was about 2:30 in the afternoon. If I can see him right now, could he see me? She calls back and says, yeah. He says, but you'd have to come over now. I said, fine. So I left and went out, had no raincoat, no umbrella, wasn't going to use it anyway, got absolutely soaking wet, got into a cab and went down to his office, and I walked into his office and I'm dripping a trail of water behind me. And he go in his office, he's surprised. I said, Mr. Rivera, I appreciate you seeing me. He said, it's okay. He says, you're kind of wet. Well, I just wanted to make sure I got here to see you before you left. He says, sit down. He says, first of all, he says, I just want to thank you for the respect you showed my people. Respect is a big issue.
Yeah.
I mean, people who are doing a job, and you have to give them that respect. And I told him, he says, this is real. And I said, it's very real. I said, we're going to need layoffs. He said, okay, I'll come and help you. So he came down personally, called all of the union workers into the auditorium, and told me, he says, this hospital's in trouble. We're going to have to help them to save it. So we're going to have layoffs. But he said, we're going to do it according to our rules, and we'll lay it out. We had not a single complaint about that. The layoffs went fine. We
Wow.
turned it around. The biggest problem I had, I think, was when I saw this, I needed consultants to come in. It's just too much to do a turnaround of that magnitude to do it quickly. So we hired consultants to come in and do this. And the biggest problem I had was fighting against the consultants who work by metrics. You know, you need to have 5 FTEs per adjusted occupied bed. You know, 1 nurse to 5 patients and so forth. And the problem was that Mount Sinai had also had a tremendous amount of bad press because there was a death of a living-related liver donor. The donor died, and he had been a reporter for the tabloids. And so they took that as a problem. So every day in the newspaper was Mount Sinai, dirty hospital, bad quality and everything. We'd had 200 complaints, formal complaints to the Department of Health. And the head of that health department was not known to be friendly toward hospitals or doctors. So we had this massive problem. The only way out of that is you have to sort of sign on each one that you were wrong and so-and-so's death, and this was what happened. Well, the fine is about $3,000, but the backup of the lawsuit was going to be huge. We had 200 of those. Quality was an issue. And so rather than firing 350 nurses, I really wanted to increase the ratio of nurses to patients to you could see that would be a quality difference. Because you needed to hire, I mean, you needed to get more patients in the hospital to survive. You couldn't just cut your way to success. You need to build it too. So I really wanted to build the quality issue so then we could bring more patients in and salvage it that way. So I spent a lot of time arguing with consultants about what to do. I also had to meet with the the health commissioner, and it was an interesting experience as well. I went and met with her, and she was ranting about bad quality, and yes, doctor, that's why they put a physician in charge, because I'm going to have to guarantee the quality of this. And we went on for a good bit, about 30 minutes of getting chewed out. And she finally says, okay, she says, we'll get ready to leave. She says, by the way, Dr. Hollier, he says, aren't you from Charity Hospital? I said, well, I was there a long time ago. She said, yeah. But she says, back in the 70s, didn't you have an NIH grant? You were working on neoanimal hyperplasia? I said, yes, I did. Now, I was really impressed. Now, she must have sent her people out to Google me or something to find out. She said, you were working with the Spanish brush goat. I said, yes, and I'm really impressed with her. And she says, you had a goat that committed suicide. I said, well, I had a goat that fell off the roof. And she says, I said, Doctor, I've got to ask you, how do you know this? She started laughing. She says, you had an NIH project and one of your subjects died. She said, I was sent down as the investigator. She says, I met with you by this. She says, do you remember what you told me when I asked you why you let your resident eat the goat? I said, no, I really don't. She said, well, she says, my residents don't make very much money, but goat tastes better than alligator, so I said he could have it. And she says, doctor, she says, I'll help you with this. She said, here's my card. She writes down her cell phone number. Here's my cell. She said, if you have any other issues that come up at the hospital, just call me right away. And she says, let's handle this together before the press gets it. And she let me take 200 complaints, signed a single response that we were deficient in the following areas, no names attached, and all of that went away.
Spectacular.
So it was a fascinating experience.
Now, Larry, in 2004, now you're back at LSU as the dean. How did you leave New York? Was the attraction of going back to LSU?
You know, I was getting into my 60s.
Still young.
I think so now it was, yeah. But I thought, you know, at some point, we're from the South, we're from Louisiana, and that was really sort of our home. So this would be a good opportunity to go back to Louisiana, still have an interesting challenge job to do. I had been at LSU and knew all the issues related to that. There were a lot of problems with the charity hospital system.
Right.
Financial problems with that. I knew what the problems were. I thought we could fix it. And it was a chance to get back home, and I thought this would be a nice way to sort of finish my career.
In 2006, you became chancellor, LSU, of the LSU Health Sciences Center. Were you still seeing patients at that time, Larry?
Yeah, still do.
Still do now?
Still operate, yes. I don't play golf. I got to do something for fun.
Now let me ask you this. Somewhere along the line in these certifications that you have, I noticed that you were a fellow of the American College of Cardiology. Now how did that happen?
Going back to the Mayo Clinic days, I worked very closely with the vascular internists. The vascular internists were all board certified in cardiology, but they had this special interest in vascular disease. And Jax Patel, one of the vascular internists, really wanted to see more integration of vascular surgery, vascular medicine, and cardiology. And I was proposed as a member of the American College of Cardiology because I was also working with the vascular medicine guys in education. We'd go to Hart House and give programs every year, and so they felt that that was an integration. So that's how I wound up there.
I'm sure that was helpful.
It was helpful that they supported this.
Yes. All right, let's talk about your awards and positions for a moment. In 1991, you were president of the Louisiana chapter of the ACS, then president of the Midwestern Vascular Society, 87. Peripheral Vascular Society, you were president in 78. SAVS, president 1995. And the Society for Clinical Vascular Surgery, president 1994. And the list goes on and on. Larry, it seems that any group you were involved in, you rose to be president, always a leadership role. Was this something you sought, or was this something that just happened?
Something that just happened. I've never put a lot of interest in titles. I don't think that's important. I think the collaboration that you get is what's more important. I'll tell you another side story on this. When I left Mayo and went back to New Orleans when I was at the Ochsner Clinic, New Orleans at that time in vascular surgery, in many specialties, but particularly in vascular surgery, was a divided city. You had LSU, you had Tulane, you had Ochsner, and you had the guys in private practice. And they all looked upon each other as competitors. And I really thought we would get a lot more out of everything if we would collaborate, share, talk together, share experiences. The question is, how do you do that when everybody's divided? So I was talking to Mac Ritchie, one of the representative of Gore.
Know him very well.
And he was at my office, and I'm telling him about this problem. I said, you know, Mac, I really would like to find a way to get them together. He said, well, you know, if you want to do something like that, he said, I'll be happy to fund a dinner or something like that. I said, I think it needs to be more than a dinner. So I was sitting there, I said, let's start a new vascular society for the local area. Let's, more than New Orleans, let's do the Gulf South. I was really thinking Louisiana, Mississippi area. I said, to avoid any kind of conflict, let's not have any officers. We'll have a president, but I'm writing the bylaws, we do this. The president cannot reside in the Gulf South. So we would appoint a president, but the president would not be anybody locally. It would have to be someone elsewhere. So there was no competition for a position. I said, we'll have meetings. We'll have the president and 3 invited speakers. And those 4 will then serve as the panel. And it'll be just case presentations, because surgeons always like case presentations. So the concept was we will have all the docs who are interested get together, and we'll just share cases. And as a concession to the private guys who were very concerned that they would be giving a presentation and might be criticized about the case, while the academic guys would have a resident present, so they would be sort of sheltered. We initially started that there would be no resident presentation. It had to be the faculty person to present that. We had 2 meetings a year. One in the spring was give us your best case, show us your successes. In the fall, it was only complications. And by bringing in outside speakers and so forth, we wound up with a situation where it became very collaborative. It became unifying for the group. So the Gulf Coast Vascular Society was started that way. We just had our 24th meeting. And that's been very helpful. To get people together is really the thing to do. That's what allows you to learn and share.
Larry, you've had a large number of editorial boards that you've been involved in, including JVS, and over 263 papers, 121 books and books chapters. With all this wild success, why you? Why do you think this happened?
I'm just a country boy trying to do a few cases, you know. This is not a...
You didn't want to work on combines.
That's right. I guess and I've told this to students and residents as they look for advice for their careers and all that. I was never really focused toward an academic career. I just wanted to operate. I wanted to take care of people. It's just that when you do things you sort of learn new techniques or other things that might be done differently, and you just want to share that. So we wind up writing about it. And I guess it was sort of an evolution. It's not something I ever sought to do.
Just happened.
Just happened.
Larry, with doing all these various things and doing them all so well, do you have any tips for us on time management?
I don't know about tips from time management. I can just tell you the way I've always looked at it. I think that if you're interested in vascular surgery, and that's your focus, then that's what you do. And the other things that need to get done, the papers or whatever, then you do that in other times when you can't be necessarily directly taking care of patients. So most of my papers and all would be done on nights or weekends or on a trip somewhere. So I think you just focus on what needs to be done. And I think you also try to take advantage of talent around you. So
Right.
you share the work.
Larry, with all this tremendous success, did you have any failures? Did you have any disappointments?
I think we've all had disappointments and all had, problems that you look back on and say, I wish I'd done something differently. We've all had that. Probably one of the most glaring issues that struck me, again, when I was at Mount Sinai, we had this death of a living-related donor, and it became a lot of notoriety about that in the transplant program. And I had just been appointed president, but I was still operating. And I remember I had a call that Mike Wallace wanted to interview me.
Ouch.
And that was a little anxiety-provoking. And I had the interview for that afternoon, and I was operating on this young woman. It was a fourth redo thoracoabdominal. And she had had a history of malignant hyperthermia. They knew about it. They were prepared for it. And I was operating on her, and they gave her dantrolene. They gave her all the appropriate medication. But toward the latter half of the case, she sort of suddenly had a cardiac arrest. And we resuscitated her, and I continued with the case, and she arrested again. And there was no reason that we could see for that. We couldn't quite understand it. She wasn't hypertensive, wasn't hyperthermic or anything like that. Make a long story short, after about 4 or 5 arrests, I finished the operation and had talked to parents. And as they were wheeling out the room, she arrested again and died. And it turned out that what was happening while the dantrolene had stopped the malignant hypothermia, it hadn't stopped the cellular breakdown, and she was getting hyperkalemic. As she lost cells, she was getting more and more hyperkalemic, and the anesthesia just couldn't quite manage it. Anyway, she died, and I talked to her family and all. And I walk out of there, and I go into the interview with Mike Wallace. And he's talking about the death of the living-related donor. And he said, well, doctor, he says, you're a vascular surgeon. And he says, I'm sure you see a lot of problems. He says, what do you do if you have a case like that dies on you? And it was a very emotional moment because I just wound up with a death. And the question kind of struck me. It's, why do you do this? When you know that there's issues, that people die. And the only thing I could tell him was that, things like that happen. And the only way that you can go on is if you believe that what you do saves more than the ones that you lose. But I think that was one of the more defining moments for me. It was a difficult thing of why we do what we do.
Another branch point.
I think so.
Larry, throughout this spectacular career, who guided you? Who did you want to emulate? Who were your mentors?
I had several mentors along the way who I think were very influential for me. My parents certainly were strong mentors. I always wanted to succeed so that they would be proud of what I did.
Sure.
Isidore Cohn was a real mentor, a man who was an intense researcher, did a lot of the germ-free animal work in the earlier days, and he would generally not operate because he said he didn't have enough time to devote to caring for the patients, so he would travel a lot and talk a lot in different areas. And I remember when I was a chief resident, I had a Whipple, and I asked Isidore to come and staff it for me. So I couldn't see finishing a program where I didn't operate with the chair.
Right.
So he came and he operated with me, and I got to say, he was spectacular. He was an outstanding surgeon. And it showed me that you really could do both. It's what you guided yourself to be. But he was always very straightforward, very committed to, if he gave his word, you could count on it. So he was a very strong influence in my life. Jesse Thompson also was just outstanding. His commitment to the meticulous care of patients was a very important issue to me.
Larry, I'd like to move now to a couple of areas that we'd like to talk about a little more, in more depth. The first thing, we've talked about your role as a medical executive, this new breed, this new role for physicians. What do you see as the necessary qualifications? Do you think we need to be MBAs? We need formal training in business? Or a clear eye to what is truly happening?
I don't think a degree is the important aspect of this. I think experience and training is an important aspect of this. For example, when I was at the Ochsner Clinic and I was elected to the Board of Management, Ochsner arranged for the 7 of us on this board to undergo sort of a crash course executive MBA training so that the Tulane Business School would come over and they would give us business issues to develop, programming, how you develop these things. And that was a good insight, a good activity to get involved in because you learn some of the inner workings of the business world.
Is that helpful?
Yeah, that was very helpful. And again, it was not a degree that came out of
Right.
there, but you got the training and input, which was important. And then the other important aspect about taking on something outside of just a pure medical care is identifying the people who are all involved in their particular area of expertise, whether it be in finance, whether it be in human resources or supply chain management. I think that's important. One of the other important things that I learned was when the Hunter Group came in to Mount Sinai to look at managing a $35 million deficit, they set up some very fascinating metrics to me. And they said, everything is a business. And I've really adopted that. Medicine is still a business. And it's got to make sense if you want to keep in that business. And what we learned from them is that they set up the metrics of the business. So that in medicine, for example, the methodology that we use is something called CARTS. And it's the aspects of the business of, say, the School of Medicine. So this is, to me, is mission-based budgeting. It's how do you budget. Went to LSU, and one of the first things that I did was I moved the school to mission-based budgeting for our financial issues. It's a business. In medical school, you do several things. You teach, you do clinical care, you have some administration, you have research, and then you have to have some strategic investment. So the first letter of all of that spells CARTS, C-A-R-T-S. So I got to New Orleans in January of 2004, and our budget year starts in July. So I worked with the chief financial officer there, great guy named Keith Schroth, who came from the oil industry of Texaco. And he was my chief financial officer. But I laid out what I wanted to do, and he put out the metrics. So we used external benchmarks. University of Virginia, for example, had written papers about mission-based budgeting and how you allocate, how much time do you allocate for an FTE to teach a course in medicine. So we used external, their benchmark was if you had 8 hours a week of direct contact with students, that was 1 FTE. You say, have it 1 day a week and that's an FTE. But when you look at an academic setting, there's mentoring of the students, there's preparation of courses, of lectures, of exams, there's administrative committee meetings that you participate in. So we laid this out. And so in June, before that fiscal year was going to start, I went back to called all the chairs together and I said, we're going to move to mission-based budgeting. You're going to get last year's budget, but side by side you're going to see mission-based budgeting. You've got 1 year to prepare. And I said, as I look at what we're doing and what the revenue's coming in, I've got 200 too many clinicians for the productivity that is here. So figure out what you're going to do. Either you don't need that many or you're going to have them busy enough to cover this. The following year, in July of 2005, we implemented it. It was relatively smooth because I was not giving in. We did implement it no matter what. And most of the departments with the basic science was in 3% of their regular budget. Clinicians had a bigger gap, but we went through with it. Now, this was in July. At the end of August, Hurricane Katrina hit. And I lost 7 of my 9 teaching hospitals in the city. All of my buildings went underwater. We moved everything to Baton Rouge, but I had layoffs I had to do. I was burning through $13 million a month. But we had laid out mission-based budgeting. We knew what our new business was, very, very much downscaled. And so when we wound up doing furloughs, we were able to do it very efficiently because we knew exactly what we were spending everywhere. And that was probably the most significant thing.
Larry, obviously you were agreeable to do some traveling. Was this something that you knew you were able to do ahead of time, or this?
By traveling, you mean move to different jobs?
Yes.
No, I have a wife who's very understanding and has stuck with me through all this.
Larry, you've been seen as someone who can solve problems, move people, and move institutions in the right direction, which I have to say is a wonderful trait. One of your former associates told me this: Larry is an organizational genius. He understands people, politics, and money. He sees through situations very quickly and knows what to do. He can make it happen and still be well liked. How do you plead to these accusations?
Probably a little too generous over there on that. I think, most people want to do the right thing. And most people want to be successful in what they do. I think the key to a lot of this is to present the vision of where you want to go, the rationale for why it ought to get there, and then ask that they figure out how they will contribute to this. So, I love to hire workaholics and then just get out of their way and let them move forward. That, to me, is what you do.
Let's talk for a moment about the clinical area that you were highly interested in, thoracoabdominal surgery. How did you decide to investigate and utilize spinal drainage?
1 year for, I think it was the SVS meeting, they had decided they were going to have some presentations on sort of a panel discussion, and there were several topics. One of them was renal preservation, one of them was spinal cord protection, I think one of them was myocardial protection, and so forth. I was really interested in talking about renal preservation because I had done kidney transplants earlier in my career, and I was interested in it. But I was assigned spinal cord protection. I knew nothing about that. I didn't think it was anything I could really know about it. But like everything, you go to the literature and you start reading up on it. And I found this article from Oka and Miyamoto back in 1961. And they had done some experiments, and they found that by draining spinal fluid in the dogs, they could have a longer safe clamp time. I had trouble with that. Why does that work? And as I went and studied more about the pathophysiology or the physiology, it became evident that the spinal canal really represents a Starling resistor. You have an enclosed bony box, a shell. You have blood flow going through the cord, and you have a variable medium around that, so that if the pressure increases, it reduces the perfusion pressure.
Right.
Then it made a lot of sense. And then I found, again, other articles, and actually Blaisdell and Cooley, back I think in early 1964, had actually used spinal fluid drainage in a patient, and they sort of used it once or twice, but then it didn't do it anymore. I asked Blaisdell one time why, and he said Dr. Cooley was sort of impatient, and it took a lot of time to put a needle in and move them around while you're operating, and he said that just didn't work. It was before they had polyethylene catheters. But I said, I've got to prove this for myself. So I had my vascular fellow at Mayo. We did a series of experiments in dogs where we drained spinal fluid and clamped the aorta, thoracic aorta, and looked at results. And if you drain spinal fluid in 30-minute clamp time, those that you drained had a much lower risk of neurologic injury. If you clamped them an hour, same thing. It was much more pronounced. So it made sense, and physiologically it made sense, and then in the animal experiments it seemed to be right. So I started using it on my patients, and we wrote the paper up, and it's probably where you're going with this. We presented this paper at the SVS meeting in 1987. And I had sent a copy of my paper to Dr. Crawford.
Right.
And asked him to comment about it. And so I sought him out the night before and thought I'd just see if he would tip me off about what questions he might ask. And I went up to him and said, Dr. Crawford, I want to know if you got my paper. He said, yeah, I got it. I said, any questions I can answer for you? He said, son, maybe it takes one to know one, but I think you're a crook. And he walked off. I was devastated. I went back to my room and read my paper again. What could I? It's animals. I got 10 dogs, drain spinal fluid, 10 I don't drain. What's going on? I was just crushed. Next morning, when I sought him out again, I said, Dr. Crawford, I don't understand what's going on. This is a straight animal experiment, you know. He says, you're trying to steal my patients. Oh, what are you talking about? He says, well, it's an animal experiment, but your last paragraph you talk about you had done this on 24 patients. I said, I'll take that out. Just leave it. So I didn't understand. First of all, he didn't agree with that concept. So my fellow presented the paper, and again, I was relatively young in my career, and Dr. Crawford got up, and he was the master. Had just published a paper, 700 thoracoabdominals.
Right.
And in his commentary, he sort of ended it by saying, you ought to be careful what you write because somebody might believe you. And I was so upset and angry, I just went up to the podium, moved my fellow aside, and I said, this is a straightforward animal experiment. Repeat it. But you know, if I had done 700 thoracoabdominals and I had a 30% paraplegia rate, I might think this is a safer way to do this. And there was a groan across the audience. I shouldn't have said anything, but I just couldn't help myself. And it was devastating. George Johnson afterwards came to me and said, Larry, I just don't know how I can keep protecting you. And so we had this debate. Dr. Crawford then did an experiment, prospective trial of spinal drainage, and his conclusion was that it had no benefit. When you went back and looked at what happened, his IRB in Houston would not let him drain more than 50 cc's of spinal fluid. Now, my protocol was following pressure, not volume, and I used 10 centimeters of water as the point it would automatically drain. But there were cases where in the first 24 hours they would drain 1,700 cc's of spinal fluid because it's a pressure phenomenon. And then ultimately, Hazem Safi repeated it but used the protocol of drainage, and he showed dramatic differences. To Dr. Crawford's credit, who I really admired a great deal, I had this confrontation, so to speak, right before I got to Ochsner Clinic. And John Ochsner and I would operate sort of side by side, and we'd share a case. He'd always come in and look over my shoulder and what we were doing, and I'd look at him. And Dr. Crawford actually was one of my sponsors for the American Surgical, which I thought was magnanimous on his part. And then I got a call from him one day, sort of out of the blue. He said, Larry, he said, we've been talking about paraplegia for a long time. He said, I'd like for you to come and spend a couple weeks with me, and let's just go through everything, and let's just come up with a definitive answer. And I was elated because this was, you know, an opportunity for us to really get some good work done, but also I sort of felt bad about the confrontation that we had had. I think he did too. So we were looking at our schedule, and I arranged to go there in 2 weeks before I was going to arrive is when he had his stroke, and we never did get together. So I was disappointed that I never did really get to work with him. But he was a great man, and it was an interesting experience for me. I tell you, I thought I was career ended on that that day.
Larry, the last series of questions that I want to bring up for discussion are strictly opinion questions. I know up to now you haven't really given your strong opinion, but now this is a requirement. The first area is to talk about healthcare delivery. This is, needless to say, become a political football. Even after our recent election, it's not changed. Do you believe we've lost our way?
I don't think I would use the term lost our way. I think we're struggling to find the right way. There are a lot of different paths you can take. And it depends on what the issues are. Is the real issue cost? Is the real issue quality? Or is it, can we deliver quality within the framework of how much it costs us to do? You know, it was interesting that I had the opportunity to work in Great Britain with the National Health Service. And at that particular time, back in the early 90s, the health service was still very dominant and very much revered by the population in Great Britain. They had really great confidence in their health system. What I saw was a nation that had very high atherosclerotic disease, high coronary disease. And there was a medical system that provided care to everyone for free, but there was access issues. For example, one of the things that really bothered me was the idea that if a patient, if an individual, working man, say 55 years old, developed coronary disease and had angina to the point that minimal exertion they have angina, he would wind up getting a cath and finding 4-vessel coronary disease, saying you need a coronary bypass, and he'd go on the waiting list. The waiting list was 18 months. 20% died on the waiting list. That, to me, while it's free health care for everybody, it's not necessarily the best health care. So I think there has to be a mechanism of identifying those at greatest risk and providing needed care. I think the way that one provides quality care is to not overwhelm the system with unnecessary care. There's a lot of things that we do in medicine that is acceptable and useful, but it's not necessary. The greatest example in vascular surgery to me is probably a fem-pop bypass on an isolated superficial femoral artery occlusion and a claudicant. We don't save limbs with that. We don't save lives. We put them perhaps at more risk if you have a failure that goes down there. So if we're going to truly control healthcare costs and provide quality, we have to change the reimbursement method, to me. I think that's the way you do this. And so I actually am a strong proponent of capitated care. I think unless you capitate specialists, however, you're not going to get the cost savings. And again, if you go back to the failed experiment of the HMOs, where a primary care physician is the gatekeeper to keep the patient away from the big bad specialists who overutilize. To me, it's the reverse of what ought to be done. Although family physicians, primary care physicians can be well trained, their perception by the population is not necessarily one that they would go to for a final answer. Again, a perfect example, Grandpa is 85 years old. He's got angina that occurs with mild exertion. He's smoked all of his life, and you know he's going to have coronary artery disease. If he sees the primary care physician is going to start the workup. EKG, that's going to be inconclusive. Probably going to wind up getting a dipyridamole thallium scan. That's going to be positive, but he's going to treat it with medication because 85 years old, treat it with medication. And this might happen 2 or 3 times, doing whatever tests they can do. And ultimately, at some point, the family's going to say, I want to see the cardiologist. Grandpa needs a cardiologist. In this country, he's going to ultimately get to the cardiologist. The cardiologist has no other tricks in the bag. Everything's been done. What's he got left? He got a cath.
Right.
And then if he gets a cath and he finds a lesion, he's going to feel obligated to treat. I think there's been no studies that show that that necessarily provides longer life expectancy or lower morbidity. So, to me, a better situation would be if you're in a capitated system where the primary care doctor or the medical home model identifies that they have something that is likely to be coronary in origin or cardiac in origin, then they ought to send them to the specialist immediately. Get that done, make a proper decision of what is the best path for this patient for this disease at that age and with those risk factors. Modify the risk factors, but not going into the cardiac cath and intervention. So to make that happen, you have to take away that stimulus for more invasive tests, more interventions. And I think we have to change the mechanism of that. I think actually academic medical centers are uniquely able to provide that type of a change. Most of our physicians are capitated in that we pay their salaries. It's how we set their metrics of productivity. Okay. Unfortunately, many times we still put their metrics by how much they collect or how much FTE RVUs they put on the books for productivity. I think that needs to change if we're going to really do this right. I think if you look at the Kaiser Permanente model, I think it's a very effective model for quality and cost effectiveness. And I think we need to move to that more and more across the country.
So you don't think politics has necessarily poisoned the well for us?
No, I think we need to manipulate the system to where the politicians can get out of the way and let us show that we can do what needs to be done. We can provide quality care and we can do it at a reduced cost. I think physicians need to partner with insurance companies. That's where I see the big difference. We need to get together so that we have the same endpoint, so that they would reward the physicians for moving in the right direction, for not doing the fem-pop in this patient population. And I think that's the way you can really control this.
Larry, the merge of SVS and ISCVS, do you think this was a good idea? Do you think it harmed international exchange?
I don't know. I don't think that I've ever gotten involved in certainly didn't have any interest in the politics of how we do this. I mean, I like the idea of having meetings where specialists of all countries can get together. We learn something different from everybody. And I think how you do that, that doesn't matter to me. I think the organizations are often done for reasons that are beyond just the educational aspects. There's politics involved in that too.
Now, since this is an apolitical question, I'll ask you about the Independent Board of Vascular Surgery. As you know, many in the vascular surgery, led perhaps by Frank Beath and many others, including myself, wanted an independent board of vascular surgery, and yet this failed. Why do you think it failed, this effort?
Once again, I did not really pay a lot of attention to that aspect of the debate. I think what I felt was always an important aspect of this is I think there needed to be separate recognition for vascular surgery.
Right.
Certifying exams or whatever you want to have as a mechanism, I think is valid. I mean, last month I just took my vascular recertification exam. You know, we do that every 10 years. So I figure I'll have another 8 years before I have to take another one. But I would hope to still be able to do that. So I've continued to take general surgery, recertification exams, and vascular surgery. I think that's appropriate. Whether it's administered under the American Board of Surgery or as an independent board, to me, is not relevant.
Relative to endovascular surgery, one Larry Hollier wrote a presidential address for the Midwestern in 1988 in which you advocated that vascular surgeons somehow should become engaged in this, become involved. You were somewhat of a prophet at that point. Larry, do you think, let me ask you several things about endovascular. One, how can this irrational maneuver of mashing the inside of blood vessels and putting wire cages, although we know it does work, how can this work? How can this be?
Well, it brings up so many avenues of thought when you bring this on. Let me take a step back again. I was at Mayo from 1980 to 1987. During my time there were the early days of angioplasty,
Right.
when Andreas Grunzig had first done the coronary angioplasty. Remember, at that time there were no stents.
Correct.
And this was in the early, I must say, maybe 85 or so. I had a young medical student, third-year medical student, who wanted to spend some time in my research lab because he had an idea he wanted to try out. His father was a physician who was a friend of one of my vascular medicine colleagues, and they, would you take this boy and let him do this? I said, fine, what's his idea? Well, he had this crazy idea. Again, this is back in 1984, 85. He thought that you could actually open up the groin, and using guide wires, you could put an aortic graft up there and replace the aorta with a new lining of this graft. And his concept was he'd put it up there in a sheath and stick it against the wall with super glue. Yeah, it's a crazy idea. I know that's not going to work. You can't do that in people. You might do it in a sheep, but it's not going to work in people. But he was a medical student, and I humored him. So we did this, and sure enough, he can get this thing up there, and he can stick it to the wall with super glue. But I don't want to kill a lot of animals on this project. It's not going to be viable. So I said, let's call the FDA. Talk to them. So we did. And they said, absolutely not. We'll never approve this. Super glue is carcinogenic. So I said, I'm off the hook on this one. So Jeff Kramer, great, innovative kid, said, keep thinking, Jeff, you think about something that really works sometimes. So he goes off a little depressed about it. Next day or so, we're making rounds, and we pass by, and there's a coronary angioplasty being done by the cardiologist. And he says, that's great. That's the way to do this. I said, well, it looks great, but stretch it out, but it collapses back. You really need something to keep it open. He said, oh, yeah. Comes back about 3 days later. He says, I got the answer. I said, answer to what? He said, these angioplasties didn't have no collapsing. He says, I've got a drawing here. He says, we can put a a stent in. Now this was in the early days before stents were available. So he had this drawing, a concept of a stent. It was not at all like the mesh stents. It was a interlocking stent. And I know this is not going to work. You can't stick things like that in a little artery and expect it to stay open, but he's a medical student. You don't want to discourage him. So Jeff, it's a great idea. Keep thinking like this. You know, you'll find something someday that's really good and can work. He goes away happy. A couple weeks later, he comes back. He says, well, we got it. Got what? He said, well, remember the stent? He says, well, I hired a patent attorney, and we've researched it. There's nothing in there, and so I filed a patent. Now I felt bad about it. I said, God, I said, Jeff, that's got to be expensive, you know. He says, well, that's the problem. I said, what do you mean? He said, well, I don't have any money. I said, well, how are you going to pay for it? He said, well, I figured you'd pay for it. I said, Jeff, why would I pay for this? He said, well, you said it was a good idea. I'll give you half the patent. I said, Jeff, half of nothing is nothing. Why do I want to do this? He said, but you said it was a good idea. So I had the next problem of going home and talking to my wife about how I'm going to pay for this patent for this kid that I encouraged when I knew it wasn't going to work. The patent was awarded for that, and then he tied the Dacron graft to the stent and filed a patent for that. His patent was awarded the same month, same year, that the first paper on aortic stent grafting was done. So he had these patents and so forth. So I learned at that point that while my inherent bias is that we can't do that, sometimes young, innovative minds have ideas that really do work, and we shouldn't necessarily discount them. As I saw more of this being done, I recognized that this was something that was going to be here to stay, because whether we as vascular surgeons think it's the right way to do it, patients very clearly see an advantage of getting a stick in the groin rather than a cut in the belly. And so this is when, in '88, I made that presidential address, right. And I said, this is coming, whether you accept it now or not. So vascular surgeons need to get on board. That's how that sort of came about.
Let me ask you one last question, Larry. What advice do you have for young vascular surgeons?
I think it's very simple. If you're going to be doing vascular surgery, do what excites you and do what keeps you interested. Never be afraid of taking a challenge. I mean, several of the things that I did in my career were never planned, but it was an opportunity that came up, and it was, is it going to be fun to do? Is it something I'd really like to do? If the answer is yes, and it's the right thing, then hopefully you'll have a wife who will support you, as mine did, and you do what you find is enjoyable in life. So I've had a great time in my career, and I hope they do too.
Larry, thank you for this interview.
Well,
Terrific.